So the first presenter we have is Dr. Burak Iran from Turkey. They'll be presenting on the relationship between spinal pelvic parameters and recurrent lumbar disc herniation.
Dear presidents and colleagues, this presentation is about relationship between spinal pelvic parameters and recurrent lumbar disc herniation. Spinal pelvic parameters have been associated with lumbar degenerative disease, particularly for lumbar disc herniation. We aim to investigate preoperative spinal pelvic mismatch as a risk factor for recurrent lumbar disc herniation in patients undergoing surgery for first-time lumbar disc herniation. Data of 1,453 patients in 6 years were reviewed. Older than 18 years old and who underwent surgery single-level unilateral fenestration microdiscectomy for the first time in our hospital selected. The study group comprised 88 patients who underwent surgery for recurrent lumbar disc herniation. The control group comprised 101 randomly selected patients who underwent surgery for lumbar disc herniation but not recurrence. We look all patients before first operation, demographic data and intervertebral disc height, segmental lordosis, lumbar lordosis, pelvic incidence, sacral slope, pelvic tilt, and sacral table angle. In results, mean age was 46 years old. The mean time to recurrence was 167 days. Both groups were similar with respect to age, gender, BMI, occupational activity level, and level of surgery. And all table mean intervertebral disc height was significantly lower in the recurrence group. And less lumbar lordosis and lower pelvic tilt at L3-4 level, increased sacral slope at L5-S1 level were considered risk factors for recurrence. In addition, in men, lower sacral slope and lower segmental lordosis, and in women, lower pelvic tilt were considered risk factors for recurrence. Pelvic incidence, pelvic mismatch, and sacral table angle were not related to recurrence. This study showed that preoperative intervertebral disc height, segmental lordosis, lumbar lordosis, pelvic tilt, and sacral slope in patients undergoing surgery for lumbar disc herniation patients may be at risk for recurrence. Thank you.
The next presentation we have is from Dr. Nishank Mehta from Delhi on design and implementation of enhanced recovery after the surgery protocol and elective lumbar spine fusion.
Am I audible?
Yes, you are, yeah.
Yeah, so good afternoon, everyone. Greetings from India. I'll be presenting our work on the design and implementation of an enhanced recovery after surgery protocol in elective lumbar spine fusion by posterior approach. So what is ERAS? ERAS is a departure from the traditional perioperative patient care that we are all used to, which places the healthcare provider at the center of the management. Rather, ERAS is a patient-centric approach to healthcare management where there is a seamless integration across different stages of a patient's surgical journey and across multiple disciplines involved in patient management. Strategic evidence-based interventions are made in the preoperative, intraoperative, and postoperative stages of patient management. ERAS has been successfully validated in various surgical disciplines, but there is limited evidence to support its use in spine surgery so far. The novelty of our study was that it was the first study to explore the use of ERAS in the context of a developing country setting. Our objectives were, first, to design an evidence-based ERAS protocol for elective lumbar spine fusion, and second, to compare its results with conventional perioperative patient care. The ERAS protocol was implemented in our hospital in December 2016. All patients operated before that constituted the pre-ERAS or control group, and all patients operated after that constituted the post-ERAS or the intervention group. Only adult patients undergoing 1 to 3 level elective transforaminal lumbar interbody fusion were included. The ERAS pathway components were selected on the basis of evidence in literature, the existing hospital facilities, and the prevalent local practices by a multidisciplinary team. The outcome measures were the length of hospital stay, the rate of postoperative complications, 60-day reoperation and readmission rate, and patient-reported outcome measures. Out of a total of 800 patients, 490 patients belonged to the pre-RAS group and 310 to the post-RAS group. There was no difference in baseline variables. We observed a significant reduction in the length of hospital stay in the post-RAS group without there being any significant increase in the rate of postoperative complications or the 60-day readmission and reoperation. In addition, we also observed significantly lower VAS and ODI score at 4 weeks in the post-RAS group, with there being no significant difference at longer follow-up. To summarize, a comprehensive 28-component ERAS protocol was successfully implemented in the setting of a public healthcare facility in a developing country. Due to time constraints, I'm not able to share the protocol in detail. The limitations of our study were the retrospective study design, a limited follow-up, recruitment of patients from a single center, and there was no measure of cost effectiveness of the protocol implementation. To conclude, ERAS implementation leads to shorter length of hospital stay and better functional outcome at early follow-up without increasing the incidence of complications or the rate of reoperation. I thank you for your attention.
Thank you.
Thank you so much. Next, we have Dr. Javier Oliveira from Mexico. He'll be presenting on endoscopic interlaminar discectomy combined with ventral epidural adenolysis. Is he there?
Yeah, I'm here.
Okay.
So I want to share my screen. Okay. Can you see my screen right now?
Yes, you can. Yeah.
Okay. Thank you very much. It's a great pleasure to share our research in this virtual world Spine 2020. I'm going to talk about endoscopic interlaminar disectomy combined with ventral epidural adenolysis for patients with disabling radicular pain. I'm Dr. Javier Oliveira from Querétaro City, Mexico. As you know, the patients with chronic nerve root treatment because this herniation and disabling dysesthesia usually persisting with symptoms after disectomy. This is because the severe chronic inflammatory process can distend the epidural vessels, form tight adhesions, and fix the nerve. And this can be risky when you perform endoscopic approaches to decompress the nerve. So we conduct a report to know the intensity of remaining postoperative symptoms from patients with chronic and disabling radicular pain who underwent endoscopic interlaminar disectomy with and without percutaneous adenolysis. We perform first the adenolysis via transsacral, and then we perform the disectomy. We conduct a study from March to August 2018 in 20 patients enrolled in a prospective case-control comparative study. All patients had lumbar disc herniation diagnosed by MRI with a minimum score of 8 in the VAS for leg pain during at least 4 weeks, treated conservatively. No diabetic and osteoporotic patients were eligible, and the group 1 conformed by 10 patients underwent for the full endoscopic interlaminar disectomy only. The group 2 conforms 10 patients underwent the same endoscopic procedure plus a steerable catheter-based adenolysis and analgesia in the ventral epidural space. The postoperative clinical results were measured and compared between groups. As a result, the group 2 resulted in immediately higher postoperative VAS scores compared with group 1. Only postoperative acetaminophen was required for group 2 patients. The group 1 needed more than one analgesic drug, but no opioid was required in both groups. The time to return to daily activities was slightly earlier in group 2 compared with group 1. And summarized, the endoscopic disectomy combined with ventral epidural adenolysis and analgesia resulted in a feasible option for patients with severe and chronic preoperative pain caused by lumbar disc herniation. Thank you very much.